professor of obstetrics and gynecology at the University of Michigan and the director of the endometriosis and pelvic pain clinic there. I still am very active in clinical work. I see patients and do surgery 2 days a week, and in the rest of my time, I am funded to do research in chronic pain and endometriosis. So it's been a wonderful opportunity to be here. So these are my disclosures. I've had the opportunity, I'm currently on the board of the World Endometriosis Society and have been active in the American Society for Reproductive Medicine and the Endometriosis Special Interest Group, and I'm one of the past presidents of the International Pelvic Pain Society. So let's start with a clinical scenario. So maybe a type of patient that would be quite common in my practice and probably your practice as well. So this is Mary. She's a 29-year-old nulla-gravid woman, no prior pregnancies, and she came to my clinic with symptoms of pelvic pain. She has a history of surgically treated endometriosis. She had a laparoscopy about 3 years ago and was found to have stage 2 endometriosis with some superficial peritoneal disease as well as a 1 centimeter deep nodule in the uterosacral ligament, and all of these were excised. But she comes back to us today reporting that she initially had her pain improved for about 2 years, and now she's having worsening symptoms. So she has dysmenorrhea, so pain with her period. She has non-menstrual pelvic pain as well as deep dyspareunia. She's tried several hormonal contraceptive pills in the past, and she has not had improvement. And she does not have plans for pregnancy now. So today we're going to go through our learning objectives, and what we hope to put into context of a patient like Maria is how do we facilitate an early diagnosis of endometriosis by understanding its signs, symptoms, and risk factors. And then we're going to review the efficacy and safety of Relugolix combination therapy for patients with symptomatic endometriosis. And then finally, we will discuss how to implement some strategies to improve long-term management of endometriosis, including things like patient education, interdisciplinary care, multimodal care for different types of pain conditions that affect women with endometriosis. So endometriosis, as you all know, is a very common condition. We believe it affects about 1 in 10 women worldwide, and this prevalence is likely underestimated. If you look at specific patient populations, it's even more common. So it affects anywhere between 21 to 47% of women with subfertility, 71 to 87% of women with pelvic pain, and it's actually quite common in adolescents. So in teenagers, it affects anywhere between 50 to 75% of teenagers who present with pelvic pain or painful periods. But despite how common it is, and we've talked about this a lot in the clinic today, is that there is a very disturbing delay in the diagnosis of endometriosis. So on average, worldwide, no matter what country you're in, the delay from the time that a patient feels symptoms to when they're diagnosed is anywhere between 4 to 11 years. And so that's very sad and it's very disturbing. And so why is this? Well, one of it is that women's pain is dismissed. It's dismissed by themselves, it's dismissed by their families. Women are told that having pain with your periods is normal, and they're told this by their physicians as well. We also know that we, unfortunately, in healthcare, don't have very good training in the way to understand and to diagnose pain conditions, particularly in women. And then finally, specifically with endometriosis, there's been a long-standing history or tradition that to make the diagnosis of endometriosis, you need to have surgery. So the gold standard in the past for the diagnosis of endometriosis includes surgical biopsy. And we know as surgeons that endometriosis can look many different ways. And this is why the basis of requiring a surgical biopsy has been recommended. But beginning in 2022, multiple large international professional societies recognize that surgical diagnosis is really impeding clinical care, and that laparoscopy is no longer considered the diagnostic gold standard for the diagnosis of endometriosis. So this was proposed in 2022 by Esri, by the Royal College in Australia, and further then supported by the Canadian College, as well as the National Institute of Healthcare and Excellence, which is out of the United Kingdom. And so it now is only recommended laparoscopy specifically in patients with either negative imaging results and when empirical treatment was either unsuccessful or inappropriate. So why this shift in this diagnostic approach? Well, first is that access to surgical diagnosis may delay treatment. We know that, for many patients, they have the money and they have the access and the knowledge to get to physicians, but for many patients, they might get to a physician that doesn't know about it, and waiting to get a surgical diagnosis can delay treatment. Surgery is not always accessible for all patients, as I just said. And then finally, hormonal therapies, we know, can offer similar efficacy to surgical treatment, and so there's really not a lot of benefit for the vast majority of patients to need surgery, because we know that hormonal therapy, on average, works equally to surgical therapy. So there are a couple exceptions to this, and so what they mean by who are the patients in which surgery or medical therapy immediately is inappropriate are really only a very small subset of patients. So these include patients who strongly prefer to have surgery, so it's always a patient's choice. It includes patients who have moderate to severe pain, who are actively trying to become pregnant, because obviously all hormonal therapies are effectively contraceptives. And then it includes patients who have ovarian endometriosis cysts with features that are concerning for malignancy, or whose cysts are quite large, and there's no absolute gold standard, but greater than 5 centimeters is one option. And then finally, it also includes the very rare patients that have signs or symptoms of obstruction of the urinary tract, so obstructing the ureters, or signs or symptoms of bowel disease. So based on this recommendation, all of these international communities recommend that we make a clinically suspected diagnosis, and this is based on patient symptoms, based on physical exam findings, and based on imaging. So how do we do that? Now, this is a community of clinical health care providers, women health providers, so this is not new for me to tell you that the classic symptoms of endometriosis include pain with your periods, non-menstrual pelvic pain, and pain with sexual intercourse. And in a large survey of over 1,000 patients with surgically confirmed endometriosis, having pain with periods was the most common symptom, and it was reported in about 80% of patients. 70% of patients had non-menstrual pelvic pain, and about 50% of patients had pain with intercourse. Nearly 90% of patients had at least one of these symptoms, and the vast majority of patients, so 70% or more, had 2 or more symptoms. But it's important to recognize that any combination of these symptoms can occur. And so most commonly, patients have all of these symptoms, but you don't need to have all of these symptoms to have a diagnosis of endometriosis. Patients can also have many other symptoms, so bowel upset, constipation, diarrhea are common. Infertility affects about 30% of patients. 30% of patients have pain with bowel movements. 20% have endometriomas, and about 10% have pain with urination. In this particular sample, about 2% of patients didn't have any symptoms at all. Fatigue is an incredibly common symptom in patients with endometriosis, so about 50% of patients report that they have moderate to severe fatigue. And then risk factors include having menarche at a young age, short menstrual cycle interval, nulliparity, low body mass index. History of a Müllerian anomaly is a known risk factor. So physical exam. Well, what are the physical exam findings that might suggest endometriosis? So we know that endometriosis, the most common form of endometriosis, is superficial disease. And in these patients, there really usually are no specific findings that point to that superficial disease. However, in patients with deep endometriosis, there are classic symptoms, and these include posterior cul-de-sac nodularity, tenderness behind the uterus, and ovarian mass and endometrioma can often be palpated. And then very rarely in patients with vaginal endometriosis, you can see the lesions in the vagina. But it's important to point out that the absence of findings does not exclude the diagnosis of endometriosis. What about imaging? Routine pelvic ultrasound in general does not have very high sensitivity for endometriosis because the majority of endometriosis is superficial disease. But augmented pelvic ultrasound, so the special techniques that we do for endometriosis that looks for cul-de-sac disease, bowel disease posteriorly, has relatively good sensitivity, specificity. And pelvic MRI, which is more commonly used outside of South America or in North America, has generally high sensitivity for deep, anywhere between 91 to 94%. But again, just like physical exam findings, normal imaging does not exclude the diagnosis of endometriosis. We're going to come back to this patient, Mary. So Mary, you do her exam and you find that she has a normal size uterus. It's retroverted. There's decreased mobility as well as tenderness to palpation, some thickening in the right uterosacral ligament again, and the right adnexa mildly enlarged. She also has some pelvic floor tenderness. On imaging, she has evidence of probable adenomyosis. She has a 3-centimeter endometrioma and absence of the uterine sliding sign. So you have both physical exam as well as imaging that suggests some deep endometriosis. All right. So what do? What kind of treatment? Well, standard therapies for endometriosis that you know include pharmacologic therapy, surgical therapy, as well as adjuvant treatments. And pharmacologic therapy is really the basis of our treatments, and these include pain medications, various types of hormonal suppression. Surgical therapy includes conservative options like excision of endometriosis versus more explicative options such as hysterectomy with excision of endometriosis. And then adjuvant therapies are aimed at treating the other sources of pain, including things like physiotherapy and acupuncture. I think one of the most important take-home messages, certainly what I educate my patients on and what we talk to other clinicians about, is that endometriosis, it's really important to understand that it is a chronic systemic disease and that there's not a single treatment that is curative for all patients. And so it's really important to emphasize to patients that no matter what treatment they choose, long-term treatment is really recommended in women during their reproductive years as long as they're symptomatic. And so what does this look like? Well, treatment needs to be individualized according to patient preferences as well as goals. And the goals of treatment include reducing their pain and improving their function, preventing disease progression, and then in those patients that have surgery, reducing the risk of postoperative recurrence. So how do we do this? Well, all of the guidelines that I mentioned before, ESHRE, Australia, Canada, the UK, include first-line hormonal treatment with either a combined hormonal contraceptive. In general, continuous therapy is recommended. Progestins are an alternative that can be given either orally or through an intrauterine system or through long-acting depot injections, as well as analgesics to support their pain. However, pain can persist for about a third of patients who try these medications, and it can persist either because they don't have a response or that they don't tolerate one of these medications. And so then what do you do? So second-line hormonal therapies include things like gonadotropin-releasing hormone agonists as well as antagonists, and surgery is also certainly an option. We also consider and recommend multimodal adjuvant treatments with an interdisciplinary approach. But the treatment philosophy for the patients has evolved over time. The important thing is that with the onset of symptoms, patients should really be counseled that long-term medical treatment should be considered the standard of care as long as they're symptomatic and until menopause. And really that we need to limit repetitive surgeries and that limit surgeries hopefully to just once in the lifetime. And these are for very specific indications. If a patient desires pregnancy and they're having persistent pain, if their pain is unresponsive to medical treatment, if they have a large endometrioma, or if they have deep endometriosis causing obstruction. But then once they have surgery, resuming long-term medical therapy to prevent that recurrence is considered recommended. And there is quite a bit of evidence to support the efficacy of long-term medical treatment, because what we know is that it has been shown to significantly reduce both the incidence of recurrent endometriosis in patients as well as the incidence of needing recurrent surgery for these patients. So let's look specifically at the guidelines. And so the guidelines say that it is recommended to offer hormonal treatments as one of the options to patients to reduce endometriosis associated. And medications have different safety, different tolerability, as well as different cost profiles. And so there's not going to be a single medication that works for every single patient. We start with combined hormonal contraceptive, progestins, or an IUD because they're cheap, they're easy, they've been studied for a long period of time, but they do have side effects. So some have thrombotic risk, some can alter lipid profiles, the intrauterine system doesn't prevent ovulation and might not be appropriate for endometriomas. And so when these treatments don't work, or if they're not efficacious, we move on to second-line therapies, which can include both the gonadotropin-releasing hormone agonists as well as the antagonists. But many of these older agonists have high efficacy and high cost, but they're not very tolerable due to symptoms such as menopause symptoms like hot flashes, as well as decreased bone mineral density levels. The other thing to consider, aromatase inhibitors have little evidence, but that is something that you can consider as a third line. But what I was going to say is the other thing that you need to consider is that particularly in young women who are desiring fertility in the future, many of these medications have, once you discontinue them, can have quite a long time before ovulation resumes. So for things like Depo-Provera, Depo-Lupron, it can be anywhere between 3 to 6 months before ovulation resumes, and so it's not necessarily ideal for patients who are pursuing a pregnancy. And again, shared decision-making, selecting the right treatment based on the patient preference is a priority. And the goal in general, while somebody is being treated, is to achieve amenorrhea, so to not have menstrual periods, and consider more aggressive treatments if a first-line treatment is not helpful. So what is new? What is new on the market? And that is partly what we're here for today, is to speak about Ryeqo, a novel once-daily gonadotropin-releasing hormone antagonist that contains combination therapy. I had the honor of being part of the faculty that was involved in the analysis of the data and the publication of the studies, and it's really my honor to be able to present some of this information. So Ryeqo is actually an incredibly novel medication in that it contains 3 critical medicines that were specifically designed for this combination. So it includes 40 milligrams of Relugolix, and Relugolix is a gonadotropin-releasing hormone antagonist that reduces the release of follicle-stimulating hormone and luteinizing hormone that then decreases the downstream production of estrogen and progesterone, thereby reducing both bleeding associated with uterine fibroids as well as pain associated with endometriosis. The novel thing about Relugolix is an oral non-peptide. It has a very short half-life, so a very short onset of action that is orally active. But to mitigate the known negative side effects of the dramatic decrease in estradiol levels, there is add-back level hormone replacement therapy in a single dose, in a single pill. So it contains both estradiol at 1 milligram in the pill, as well as norethindrone acetate, which mitigates the effect of the estradiol on the endometrium. So the reason that it was designed in this way is based on the estrogen hypothesis of both endometriosis as well as uterine fibroids. And so what we know is that both of these conditions are extremely driven by estradiol. And with low levels of estradiol, these lesions are suppressed and atrophy. And with high levels of estradiol, it can cause these lesions to grow. The problem is that with very low levels of estradiol, this is when you get into the negative or the adverse effects on patients, including bone mineral density loss, as well as very troublesome hot flashes that can really make the medication difficult to take. But at high levels, this is where you don't get sufficient suppression and the endometriosis grows. And so what we're looking for is this optimal range in which you have optimal estradiol that both suppresses the lesions, but it mitigates the negative adverse effects of low estrogen. So Relugolix combination therapy was studied in two pivotal trials called Spirit 1 and Spirit 2, and then looked at in the long-term extension study. So the pivotal studies included women who were 18 to 15 years old. They needed to have a history of surgically visualized endometriosis and needed to have moderate to severe dysmenorrhea as well as non-menstrual pelvic pain prior to randomization. The study did exclude women who had evidence of low bone mineral density. There were approximately 630 some women that were randomized each individually in a 1-to-1-to-1 ratio in each of these studies. And so women were randomized to either placebo, to Relugolix combination therapy, and then in the third arm was to Relugolix monotherapy for 12 weeks, and then followed by combination therapy. And while Relugolix monotherapy is not available clinically, the reason that this was done was that the FDA required the company to demonstrate the benefit of giving add-back therapy, and so that arm was studied. The primary endpoints were at 24 weeks, and then patients who completed the pivotal studies who did not have a decrease in their bone mineral density score greater than 7% were eligible to continue in an open label study in which all of the patients were then continued on Relugolix combination therapy. So those patients who were on placebo were then all switched to Relugolix combination therapy, and then they were followed for up to 104 weeks or 2 years. So what were the co-primary endpoints? So the co-primary endpoints were defined prior to the study as a proportion of women who had more than a 2.8 point reduction in their dysmenorrhea score from baseline over the last 35 days of treatment and no increase in analgesic use, plus the greater than 2.1 point reduction in their non-menstrual pelvic pain score, again with no increase in analgesic use. So it was a co-primary endpoint that you basically had to have clinically significant improvement in your pain with your periods, as well as clinically significant improvement in your non-menstrual pelvic pain. They looked at a lot of other secondary endpoints, but some of the critical ones include their change in their baseline numeric rating scale, so a 0 to 10 scale in their painful periods, non-menstrual pain, as well as dyspareunia. We also looked at the endometriosis health profile, which is a validated tool looking at quality of life as it affects women with endometriosis, as well as analgesic and opioid use. The safety parameters included looking at adverse events as well as bone mineral density. So the co-primary endpoints are shown here, and what they found was at 24 weeks, Relugolix combination therapy was associated with a statistically significant response rate for both dysmenorrhea and non-menstrual pelvic pain. And so what we found is that at 24 weeks, about 75% of patients in both Spirit 1 and Spirit 2 achieved that improvement in dysmenorrhea, and around 60 to 65% achieved that clinically significant improvement in non-menstrual pelvic pain. When you look at the improvement of these symptoms over time, so this is looking at dysmenorrhea scores during the treatment area, which is in gray, and then through the extension period, what we saw was a rapid decline in dysmenorrhea. So the vast majority of patients had clinically significant improvement, so from severe pain to minimal pain by 8 weeks. And then during the extension period, so the placebo patients are in that top line gray. So as soon as they got switched from placebo to Relugolix combination therapy, you saw a dramatic decrease in their dysmenorrhea scores, and so there was approximately 83% improvement in dysmenorrhea by week 100. By week 52, and then 84% improvement by week 104. When you looked at non-menstrual pelvic pain, we again saw a significant decrease. So somewhere between 12 and 16 weeks, you noted a significant decrease, or a clinically notable decrease in their non-menstrual pelvic pain. By 52 weeks, there was, on average, a 63% decline in their non-menstrual pelvic pain scores, and then at 104 weeks, about a 69% improvement. The time to no minimal pain or no pain for dysmenorrhea or non-menstrual pain was also looked at, and this is, I think, very helpful data for a clinician, so that when you see a patient and say, when you start this medication, about 50% of women will achieve little to no pain in their periods by 8 weeks. And about 95% of patients by the end of the 2 years report minimal to no dysmenorrhea. So it's highly effective for dysmenorrhea. And for non-menstrual pelvic pain, also very effective. Over 50% of women report minimal to no non-menstrual pelvic pain by 28 weeks. And then at 104 weeks, so by 2 years, about 70% of women report improvement in their non-menstrual pain. And I found this to be particularly interesting because it's important to tell patients, when you're at 8 weeks, when you're at 12 weeks, 20 weeks, you actually might continue to find improvement over time, especially for non-menstrual pelvic pain. And so if patients are beginning to see an improvement continuing on the therapy, you can assure them that many more patients will continue to have even greater improvement the longer they are on the medication. Secondary endpoint for dyspareunia also showed dramatic improvements in their dyspareunia scores. You can see that as early as 8 to 12 weeks. By 2 years, on average, there was about nearly a 60% improvement in their baseline dyspareunia scores. The FDA, this wasn't part of the primary endpoint, but the FDA secondarily asked about opioid use. And what they found is that by 24 weeks, so at the end of 6 months, 86% of women taking the Relugolix combination therapy in Spirit 1 and 82% of those in Spirit 2 became opioid-free. And that this was, while the clinical relevance of this has not been demonstrated, it is a substantial, clinically important difference that, I would say, based on the patients that were not taking the medication. What else do patients want to know? Well, how much am I going to bleed? The amenorrhea rates are actually quite high, so having no menstrual bleeding was quite high. So by week 12, over 50% of patients reported no bleeding at all. And by week 52, nearly 80% of patients reported no bleeding. The vast majority of the patients that had some bleeding were really only experiencing some spotting, not enough to fill a pad. The other thing that I think is very important to explain to patients is that not only do you quickly achieve no periods for the vast majority of patients, once you stop the medication, the average time to resume ovulation and to resume your menses is about 1 month. So it actually is a very quick time to resume regular menstruation, which is very important to patients who are looking for pregnancy after discontinuing medication. Adverse events were actually not common. So these are the adverse events that were reported in more than 5% of patients. The most common is headaches, but what I would say is that headaches are incredibly common in patients with endometriosis. And overall, the incidence of adverse events with Relugolix combination therapy was very similar to what we see in placebo. And so when you look at all of these adverse effects, the patients taking the combination therapy reported very similar rates to those on placebo. About 3% of patients reported serious adverse events, and the most common serious adverse events included hemorrhage, suicidal ideation, cholelithiasis, but only about 5% of patients discontinued the medication due to any type of adverse reaction, and the most common type of adverse reaction that caused discontinuation occurred in about 1.7% of patients, and that included mood-related disorders, which we know is not uncommon in any patient that's using some type of hormonal management. So how safe is Relugolix with regards to bone mineral density? And so they looked at bone mineral density both in the lumbar spine as well as in the hip. And what we found is that there was a very slight decrease in bone mineral density, so less than 1% in the initial 24 weeks, which is not considered to be clinically significant, and that this did not progress during follow-up. So on average, through a full 2 years, there was less than 1% mean bone loss in the lumbar spine. We saw the same thing in the hip with less than 1% mean bone loss in the total hip density over the 2 years. Relugolix combination therapy, we also saw that significantly improved patients' quality of life. And so as we know, patients with chronic pain with endometriosis have significantly reduced quality of life due to the pain associated with endometriosis. And this was measured specifically in the SPIRIT studies using the endometriosis health profile. And this was one of the main secondary outcomes, looking at the endometriosis health profile 30, specifically on the pain domain score, which looked at the impact of pain on daily function. And what we found was a significantly improved function in patients on Relugolix combination therapy. And then when you looked at many of the other endometriosis health trial domains, including self-image, emotional well-being, social support, we saw the same thing. Patients reported a significantly improved function as well as cognition in all of these domains. So in summary, Relugolix combination therapy for moderate to severe pain associated with endometriosis is highly effective. By 24 weeks, 75% of patients reported clinically significant improvements in painful periods. 62% reported clinically significant improvements in non-menstrual pelvic pain, as well as significant reductions in dyspareunia. And more women were opioid-free at 24 weeks compared to those patients taking placebo. And I think the critical thing is that all of these were sustained for at least 2 years following treatment in the long-term extension studies. The most common adverse reaction were headaches and vasomotor symptoms and mood disorders, but in general, these occurred in less than 5% of patients. So let's go back to Mary. So Mary, as she said, in addition to her dysmenorrhea, non-menstrual pelvic pain, was experiencing fatigue and headaches, urinary frequency and bloating. We talked about her exam and her imaging findings. We're going to talk to her about medical management of her endometriosis, but is there anything else to consider when you're thinking about patients as a whole patient, not just their painful periods, but as their whole quality of life? So one of the things, and this is one of my areas of research, is that in patients that have chronic pelvic pain, while endometriosis is a very important aspect of it, there are many other things that can lead to them experiencing pain. And so when your treatments for endometriosis, your traditional treatments for endometriosis are not working, maybe we shouldn't just always blame those treatments, but think about, well, what are the other things that can be causing? And so we know that patients with endometriosis can also experience neuropathic pain or pain because lesions are directly infiltrating nerves. But one of the other things that they can do is they can have a lot of cross-organ sensitization. So the uterus is very close to the bowel, it's very close to the bladder, it's very close to the pelvic floor muscles. And even if the endometriosis is not directly invading those muscles, the sensitivity in the uterus and in those nerves that are being supported by the same nerves in the other pelvic organs can become sensitized. And so patients are more likely to feel sensitization in those pelvic organs. But we're also beginning to understand that this can actually also lead to widespread pain throughout the body through mechanisms called central sensitization. And this is one of the areas that my laboratory specifically studies. And we believe that endometriosis is one mechanism by which patients can be sensitized through the brain to become more sensitive to all types of stimuli, including pain. And so what we see in patients with any type of chronic pain disorder is that these pain disorders actually often cluster. And what they're referred to as chronic overlapping pain conditions. And so what this is a group of overlapping pain conditions that are very common in the same patients. You can have any combination of these conditions at any point in time. And so it's quite common that when we see, for example, in patients with endometriosis, compared to patients without endometriosis, they're almost 20 times more likely to have a chronic bladder pain condition. They're 16 times more likely to have vulvodynia, 5 times more likely to have irritable bowel syndrome, even when the endometriosis is not actually invading the bowel. They're 4 times more likely to have fibromyalgia and 3 times more likely to have migraine headaches. So when we see patients that have a gynecologic pain condition like endometriosis or adenomyosis, we need to make sure we're evaluating them for all of the other pain conditions that they're more likely to have, so including these shown here. And so we need to treat the endometriosis, but we need to look at the whole patient. And we need to make sure that we're treating their irritable bowel syndrome, we're treating their interstitial cystitis if they have it. Physiotherapy is a critical part of treatment because the vast majority of patients with endometriosis also have pelvic floor myofascial issues, and many of these patients are sensitized. And so with sensitization, it's really important that we do pain education, that we do cognitive behavioral therapy, that patients are treated with exercise and 10 units. All of these can be very helpful. And there's a growing body of evidence that even amongst patients that have sensitization, one of the reasons that they might not be responding to usual treatments is because they're sensitized. And so we've done studies, and other groups have done studies that say even if you treat the endometriosis, if you are sensitized, you are more likely to not find those usual treatments to be helpful than patients that are not sensitized. And so again, pointing back to look at the whole patient and not just the lesions. So moving forward, certainly the center of discussion is that patient with her gynecologist. But that is the old model. The model that we should be striving for and the model that we saw in the hospital this morning is a very broad interdisciplinary care. It involves the surgeons, it involves a reproductive endocrinologist, it involves psychologists, nutritionists, complementary therapy, pain management. The people who are doing the imaging experts, the patient support groups are incredibly important. And we need to go to this model where long-term medical therapy using an interdisciplinary approach, looking at the whole patient, and what the patient wants and what works for her as the center of our care. So what did we end up doing for Mary? So in this particular patient, it was clearly based on her exam, based on her symptoms, based on imaging, that she had evidence of recurrent endometriosis. She didn't want another surgery, and another surgery isn't the first place that we should go because surgery always has risks. And so she wanted to try another hormone option. She had tried combined hormonal contraceptives in the past. They didn't work. And so she wanted to move to a second-line therapy, and Relugolix combination therapy was ideal. She did not have any contraindications. She was happy with the single once-a-day dosing. She was happy to know that when she stops the medication, she would have resumption of her periods when she was planning on becoming pregnant. But she had other sources of pain. We talked about her pelvic floor. We prescribed pelvic floor physiotherapy. We talked about pain education and how pain affects, quality of life in the whole body, and talked about exercise and diet changes. And then we'll see her back in about 3 to 4 months. But when you're specifically looking at the recommendations for Relugolix combination therapy, I think it's really important to talk about exactly how you take this medicine. And so in my experience, the things that I tell patients is that endometriosis is a chronic condition, and there's not one single therapy that works, but we need to do treatment throughout the reproductive years. Specifically for Relugolix combination therapy, it's once daily dosing. I advise the patients to take it at about the same time every day. They can take it with food, without food, it doesn't matter, just consistently at the same time every day. There is a recommendation to consider a DEXA scan to check bone mineral density prior to initiation. It is not absolutely required, but it should be considered, particularly in patients who have risk factors for dyspareunia. The ideal time is to start in the first 5 days of the menstrual cycle, like any other type of hormone suppression. You can start later in the cycle, but the likelihood that they'll have more breakthrough bleeding in that first month is higher if you wait longer than the first 5 days. They should use backup contraception for the first month, but after this, Ryeqo does inhibit ovulation and provides adequate contraception. You typically expect to see, so I tell patients I expect to see a substantial improvement in their painful periods by 8 weeks and in their non-menstrual pelvic pain and dyspareunia by 8 to 12 weeks. But if you're doing well, continue on that therapy because many patients, as I showed in those time life graphs, will continue to have further improvement the longer they use it. Amenorrhea rate, so having no bleeding, is extremely high. Over 50% will be amenorrheic by the end of that 3 months and 70% by 1 year. But amongst those patients who are not amenorrheic, most of them are actually just having spotting. So having heavy bleeding, like a period, is actually quite uncommon. And that this generally is a very well-tolerated medication. The frequency of adverse effects is quite similar to patients taking placebo. And then once a patient's thinking about pregnancy, they stop the medication, and on average, most patients will get their period back within a month. So in summary, Relugolix combination therapy is a highly effective medication. It consists of once daily dosing for patients, both for the indications of symptomatic endometriosis as well as moderate to severe symptoms and fibroids. By 24 weeks, patients report a statistically significant improvement in all of the subtypes of pelvic pain, so it includes dysmenorrhea, non-menstrual pelvic pain, as well as dyspareunia. It's well tolerated without a clinically significant loss in bone mineral density. And finally, treatment efficacy is sustained for at least 2 years, which is, really the critical thing that we need for patients that have a chronic disease. So thank you very much, and I'm more than happy.
Muchas gracias, Susi. Por acá, por favor.